All right, so I'm Don Lee from Buffalo. I work at Algonquin. We'll just launched a product called ZenPRM. I'm the product manager of that, and I am the steward of this HC Biz community, which we've been doing now for 9 weeks. And we're trying to identify where all the things that create friction in the business of healthcare and what makes it hard for us to do business and hard for us to innovate, and focus on solving those problems or accepting them and working them around them, as we've discussed a couple of times. And Shahid's been joining me. And do you want to go ahead and quick intro?
Sure. I'm Shahid Shah. I run a company called Netspective. We're in the business of helping innovators, builders of their systems understand what markets they're in, figure out how to do product market fits, and then where necessary, actually help build products and services so that they can sell into those markets. I just got off a couple of events last week at HX Refactored, the Healthcare IT Marketing Conference. Next week, I'll be joining the World Orphan Drugs Conference. That's going to be an interesting one, focusing a lot on, and why it's interesting on the business of healthcare for the orphan drug side is that often the orphan drugs and other life science areas that don't get much attention because the market sizes aren't big enough, turns out that there's a good enough a number of patients that, because of digital tools and next generation technologies, we can see that the market is easier to reach, less expensive to reach, and perhaps even have enough data to build out new technologies for these kinds of disease conditions that are much more narrow. And you guys have heard me talk about that before, is that chase narrowness in healthcare because it is a little bit easier than trying to go too broad. So welcome, everybody. I'm happy to have others join in that would like to join.
We've got one taker here, Mr. Wherefore, coming in. So that's what I actually hope to start with is Hey, Chuck, how are you?
Good.
You mentioned, Shahid, you were at the shows last week, Healthcare Refactored, and also the HITMIC conference. And we had talked about those on your way out 2 weeks ago. So I wanted to start there and see, outside of what you just touched on, anything really interesting come up at either of them.
Yeah, so at HX Refactored, just as a reminder, is one of the only annual conferences focused on healthcare's design process. So that means user interfaces, design experience, et cetera, as well as the engineering process. So how do you build, how do you create technologies, do the proper requirements, do you connect into the cloud, et cetera. So very, a lot of folks that I just love hanging around with, which is design folks and builders. So that was the focus. And Susanna Fox was there talking about HHS. So she's the newly minted Chief Technology Officer, and many of us in the social media field, of course, know her because she was she's been hanging around a lot of us for the last few years. So Susanna talked a lot about how to move beyond just pure software and into wearables, devices, and focus more on the hardware side of the digital health equation. So I found that very both appealing as well as interesting, because before that we've had a lot of discussion, very necessary and very important, about software ecosystems, the data ecosystems. So Brian before her and Todd Park before her were focused on those areas. But I really liked how Susanna was helping us understand that the maker movement, where patients are taking control of their own destinies in many cases, can only be embraced if most of us are also focusing on hardware in addition to software. So that was important. The governor of Massachusetts spoke, and he talked about the opioid problem. You know, there's a lot of discussion around pretty much everywhere, especially with President Obama also being at a conference last week speaking about opioid addiction. And so this idea of potentially using next generation technologies to assist with these rapidly occurring kind of diagnostics and therapeutic issues was very, very important. I did a little keynote in the morning on a formula for success. So there, I will post the URL for that deck. It's at speakerdeck.com/Shah, where I presented a discussion of how and we have Mr. Workflow sitting right either next to me or beside me or to the bottom of your video. And so a lot of that discussion was about where we can fit workflow along with the context associated with that workflow into the mix of the integration discussion. So whenever we talk about interoperability and integration, we often talk about data as if by itself that has an enormous amount of value. And in some respects, it has good value because it begins the other parts of the discussion. But when we really say that we're having problems with integration and interoperability, it's that our workflows aren't matching up because the data either isn't making it, or the alignment doesn't occur, or there's no context as you move from system to system. So that was a good discussion in that morning. Then I chaired a couple of panels on cloud platforms, which I found very exciting. The guys from PocketDoc, Athena Health, and a few other of our platforms vendors were there because, and guys like, for example, Redox, talking about how platforms are now more than just saying we should be doing platforms. Those platforms exist. Thousands of transactions are being processed by minute, millions by year. So there's a lot of healthcare platforms that are in better shape than they've ever been. By no means are they at a point where we can start to rely on them for the majority of healthcare transactions. But I was very excited that the amount of progress that's been made over the last couple of years. And the panel, basically, I had folks from each one of these vendors talking about not what might we do in the future, but what have you done over the past year, which means it lets us figure out what is possible today. Like, we have to stop talking about what might be possible in the future, and let's talk about what's there today. And then I ran a panel on DevOps in healthcare. So I invited Dr. Julian Goldman, David Chow, who just left advisory board company, and a few other folks to talk about why DevOps, which is getting picked up in a number of other environments outside of healthcare, is really not making its way into healthcare as quickly as it should. And so just as a summary, DevOps is to operations and deployment of software and hardware and solutions what Agile has been to business models, or Agile has been to software engineering. So lots of great discussions there around DevOps. And I invited specifically Dr. Goldman because Julian talks about the idea of medical device connectivity, medical devices integration, safety critical devices, and how if they're not connected well, we're not going to see a lot of improvements in data interoperability over the next couple of years. So that was a very interesting topic. And the design, again, at HX Refactored, the design components were heavy. So our friends at MadPow, who are the co-sponsors, along with Matthew Holt and Health 2.0, I shouldn't say co-sponsors, they're the co-organizers of HX Refactored, did a beautiful job talking about all the expertise and effort and availability of design capability, design thinking now being applied. And what I really liked, it was beyond software and systems, applying design thinking to healthcare as an industry, not digital health as a component of the healthcare industry. And so there are a lot of great sessions there. Many of these were recorded. So if you guys in the audience get a chance to go to hxrefactored.com and grab some of those videos, I don't know when they're going to be posted, but many of them may already be up. So some of us posted our speaker decks already, so those might be available. So let me stop there. I didn't talk for a while, so let's chat about HX Refactored first, and then we'll talk about HitMake, because that was also fun.
Yeah, right on. So the HXR, that was my experience there too, is that everything was about what have we done? What are we actively doing right now? That's what I really loved about that conference. And what I like about the first panel that you mentioned is the vendors coming up and talking about very specifically the progress being made in these integrations and then getting the data moving and making it available. So amidst all of the politics about it and the news stories and the bad stuff, basically, it's good to know that there are people in the background making progress every day and connecting these stuff, despite what the rhetoric is. So that's positive. And
it for sure was. It was really interesting how the guys from Aptus Health, I was surprised at as to how much work they've done. They've been building out a number of different platforms around the content side. So having a place to go to say that you can have an end-to-end solution for the content you need when you talk to patients, et cetera, was another big deal. So, I mean, it's one thing to say we have platforms like Athena Health connecting up at APIs. It's a whole nother thing to see guys like PocketDoc and Aptus Health, Redox, and others that are basically in that integration of content, integration of the payment side. So we now have the ability to say that minor building blocks in some respects, major building blocks in other respects are there. So both Athena and Allscripts are showing how you can think differently. And these are real platforms. I mean, I was very impressed with the discussions that we had with Athena and how sophisticated they were. I mean, they actually have a site where you can go, you sign up, there's a test account, you can get your API keys relatively immediately. There's a marketplace, they help you sell, they help you bid. So I was very, very, I wasn't surprised because I've known Athena's capabilities for a while, but I was pleased that they would be able to explain it to developers in a way to say that these are not just platforms for us to talk about and say, hey, this is cool to have interoperability, but this is a platform where you can actually, because this is the business of healthcare, you can make money off the apps by tying into Allscripts or tying into Athena Health and these other kind of platforms. So this is a true developer platform where if you spend money attempting to build this kind of capability, there's a place where you can actually market and sell your systems and solutions.
Yeah, I spent a lot of time looking into the, not the Athena Health, the other one you just said, Allscripts, sorry, at the HXR last year. And I was impressed with all the things that they would do from you too, from the marketing standpoint. So there was a cost to doing it if you rolled out through them. They were looking for a good percentage of revenues to do it, but they're opening up a huge opportunity that you otherwise wouldn't have to have access to these live customers. They're going to market for you, put it up in their stores, and basically help you promote. So it's an interesting approach for small companies that don't have those means today.
That's exactly right. And I'm usually okay. Let's say, for example, that you're paying 25% of revenue. Well, you would have zero of that revenue if you weren't going through their platform. So it's not actually a bad way to go forward and say, all right, I can build something pretty quickly because the technologies are not that hard if you're going to use their systems. I mean, they're still nascent in the sense that in other platforms, you can actually take and build out, and this is where we spent a little time talking about it in the cloud session. You can't actually build out an entire stacked, top to bottom stack a component or a widget or something, and then push it through the EHR. But that's coming up next, right? So right now they can connect your external system with their system with a limited amount of context connectivity and other things. But next year, when we bring them up at HX Refactored and have the conversations, I would not be surprised if they'd be using, and they haven't announced like they're going to use Smart on Fire or something else like that. But I wouldn't be surprised where they allow widgets to be next. And then after that, you can put entire components in there to connect with workflows and context. So, very, very exciting with respect to how far they've come in such a short period of time, but also because they're doing this in a very business-friendly, monetizing, focused way, we know that these are sustainable. If they were just ideas, like pushing out, hey, we're going to, sign up with this pledge and do interoperability, those don't mean much, right? But if you've got a platform where you can onboard developers and developers can start making money on it and people share that money with the platform provider, that's a sustainable business model that can last as long as customers are paying for something valuable. So those were all very, very good. And I spent most of my time just as a developer in the engineering side of the equation. But I'm sure if there were any audience members, by the way, that were at HX Refactored last week and were able to spend time in the design side, like I was in one of the design sessions for how to design new member experiences. The folks from AHIP helped sponsor and set up that one. And so designing next generation insurance member experiences and how to tie that to digital health. So all good day-to-day kind of solution kind of work is what we were focused on. So it's very fun.
Right. Awesome. And just one last thought on the number you threw out, that 25% they're looking for on the revenue side. If any of you are considering this and looking at that as a big number, don't undervalue the basically the pipeline that you get for that and how much you would spend to build your own sales pipeline. And don't underestimate the value of the marketing that they're doing for you, because all of that is work that you'll have to do on your own. And that stuff adds up. It takes time. It distracts you from other things that might be more in your wheelhouse. So I agree. It sounds like a big number, but it could work for you in the right scenarios.
Yeah, and you're exactly right, Don, about that. And what I was surprised about with Athena is they mentioned that they will actually help you with biz dev. They'll help you find your first couple of beta clients, et cetera. So, I mean, that you and I, who have been doing this for a number of years, know how hard that is. And we would pay gold, right? To say, okay, you're going to introduce me to a client, you're going to help me onboard them, et cetera. Now, I don't know how far they'll take you in, but the fact that they were they were talking about that at all was impressive.
Yeah, it closes the credibility gap for you at least a little bit. So,
that's right.
Chuck, we haven't gotten to you yet. You pulled over on the side of the highway. You're a trooper. Mm-hmm. Welcome.
Hopefully I'm a trooper and there isn't a trooper next to me.
So anything to add on what we talked about so far?
Oh, yeah, well, everything that you too much. But relative to hardware and makers, I'm on my way to SciFest with Mr. Rimp. This is he's in pieces. Otherwise, I'd do a demo, but you might see parts of him in there, Mr. Rimp.
Yep.
You can sell my hardware and so forth, clippers and SciFest is the USA Science and Engineering Festival. It's in Washington D.C. I moved to Columbus, but we still have an apartment still there, so I'm driving to there but yeah, hardware. The very interesting implications for data capture, data management. We're seeing a lot of some of the most advanced sort of plug and play, almost self-aware, workflow-esque platforms are in the Internet of Things space. There's probably half a dozen sort of, big platforms and then some standards. I'm thinking of Samsung and Intel, and I think Amazon just came out with a platform, IBM, Bluemix. But anyway, on Friday, HITSM, I'm actually moderating the tweet chat from the floor of from SciFest on makers in healthcare.
Neat.
So look for that.
I'm coming out. I'll be coming out.
Fantastic.
I think I'll come out on Saturday, but I didn't know you were doing that on Friday. Maybe I'll come out then.
Yeah, well, I got press credentials, so I'm doing the sneak peek on Friday, and then I'll probably do periscopes of some of the stage events and so forth. Okay, the other thing I wanted to mention was, so it had to do with kind of what you were talking about with Athena and Polkadot and so forth. Tonight at 8 o'clock, I hate to do this, but I do show up to other people's blabs all the time. But there's a blab with Alex Meshkin of Flow Health, I believe. Maybe I might not have that right, but the topic is healthcare operating system. So the idea of the functions of an operating system protect you from the hardware. They deal with persisting data. They deal with virtualization. They deal with concurrency, which is a big issue when you're talking about workflows. And so that's tonight at 8. And actually I looked at since 2007, I found about over 24 examples where people either invoked the healthcare workflow operating system as a great idea, and then actually some vendors who brand themselves that way. So, you cannot build that concrete analogy, the healthcare operating system, which is scheduling tasks, executing applications, and supporting the peripherals. The peripherals are, of course, people, supporting them, because they're the analogy of the printer and the monitor. They're where the rubber meets the road, where the patient experience occurs. So yeah, it's just fascinating stuff. I just wanted to see if this would work. I'm in the middle of the countryside. I'm on my smartphone. Can you hear me okay?
Yeah.
Yeah, it works great. We can tell you're
Fantastic.
in the car. countryside, and it works great.
Yeah.
You can see the cars going by here.
Very nice.
Okay. Well, anyway, by the way, I listened on social radio. It's really cool. You're driving along, and my car speakers are enunciating all of the tweets very nicely. And I'm just going to let this blab run, but I'm not going to drive and blab at the same time. But I'll just listen to it in the background. And again, I want to thank Shahid and Don Lee for you spotted a great sort of I don't know what a hole or a lacuna in the kind of the healthcare social media, which is the HC Biz topic. And so I think I've made almost every one of them, and I look forward to many more.
Yeah, we appreciate your support, man.
Appreciate you catching up.
And hopefully I'll see you on the blab tonight.
Please.
Cool. So Shahid, we can jump back then and talk about the HITMIC conference that you were at last week too.
Sure. Yeah. HITMIC was a completely different experience. So HX Refactored was all about the engineering and design side. And what I'd recommend is in the conversation tonight about the operating system, let's all focus our attention, again, beyond saying that the platforms can help us connect technologies. We've got to figure out and say that a platform isn't really a platform if it can't help you monetize, it can't help you take your systems and sell them, have a marketplace around it, et cetera, over time. Obviously, when you're building an MVP, something is starting out, it's understandable, but we've got to now start thinking around how to make these platforms more valuable by helping customers, their customers, which are builders, monetize. So that was the general gist of HITMIC, which is okay. So now you've built what you've got. You have a good understanding of what technologies to produce, et cetera. Now that you've built it and you think you've got a little product market fit, how do you actually get this out and into the marketplace? So in the end, it's about revenue. And so if you can't actually push this information technology or hardware, et cetera, out into the marketplace, it can't work long term. And so we had a whole bunch of topics. And so it's about a day and a half, almost 2 days actually, out in Atlanta. And this is the third year of HITMIC. And HITMIC is the Healthcare IT Marketing Community. The C stands for community, but the conference, when it first started out, HITMIC and the C in the HITMIC was conference. So now we have a conference, and we've thought about doing either monthly or other, both blabs as well as in-person meetups. And so at the conference, we had a whole bunch of different discussions. Number one, how do marketers in healthcare IT really build their careers around it? Because one of the most difficult things about healthcare IT is that it's at the nexus, it's at the middle of so many different things. You have to understand healthcare. You have to understand not only what product you're building, but the jobs that your customers are trying to do. You have to then understand what are the best mechanisms and times that they can reach those messages and the marketing that you're trying to push to them. It's a very, very difficult job. And so healthcare IT marketing being a central focus for us, started with topics like, what does SEO mean when you're marketing to patients versus marketing to physicians? What does institutional B2B marketing mean, and how do you make that happen? Because it's so complex an environment, there's no non-consensus driven single decision maker. How do you build content? How do you go out and talk through them? So if you go to hitmic.com, which is the community site, and click the link for the conference, all of the speaker decks that the speakers were willing to share, which is about 90+% of them, are already online. So you can already get them. The conference topics are there, and the speaker decks were there as well. One interesting one, because I was helping with the organizing and the speaking, I didn't get to go to all of the sessions, but I'm now pouring through all of the materials that they posted. One of the most important ones that I saw there was on direct primary care. What that means, how it's going to be promoted, what could these new technologies look like in an environment where people don't actually have to go into offices. So how do you market in those environments? So direct primary care was a topic that came up last week, but another one that I think you guys might find, if you haven't seen the new CMS CPC Plus, Comprehensive Primary Care Plus initiative, if you've seen, so comprehensive primary care came out back in 2012. CPC Plus was just announced this week and will now be turning on in January 2017. What that allows you to do is it's kind of like the managed care movement of the 90s, which said, we're going to give you a pool of a population pool of N number of patients. Let's assume it's 1,000 or 10,000. And then what will happen is that managed care companies were responsible for those 10,000 patients, but it was led by payers. And so it was managed care from a payer perspective. CPC Plus, which is very interesting, is from the primary care perspective. So there are two tracks. One is a simpler track where you say, I get $15 per patient per month. I have 1,000 patients, so I have a fixed baseline fee that I'll get. And then I can buy whatever technologies I want. I don't have to worry about reimbursement, et cetera. As long as I can keep these patients healthy, I get a benefit from a population perspective. And then if I have shared savings, I can actually make more bonuses. Now, this doesn't replace the fee-for-service program, and it's in its infancy with respect to all the regulations and everything around it. But this is absolutely worth taking a look at. I mean, if you're wondering about the healthcare business and how techniques, technologies, processes, procedures can be implemented without having to worry about all of the intermediation and the reimbursement associated with it, this is great to look at, because now telemedicine, remote care, et cetera, if you can show that they work in the CPC Plus model, I think you'll be able to notice really quickly that they might work in a traditional fee-for-service model as well when they grow out of the CPC model. So that, and I brought that up because if you think about HIPMIC and you're like, well, this is about marketing, what does this have to do with CPC Plus? What does it have to do with direct primary care? There are brand new models of care that allow you to market the same products that you built quite differently. And what had less value or almost useless in a fee-for-service model last year might actually be super valuable next year in a model in which things like, we've talked about accountable care, but this model around saying that primary care has the not just a gatekeeper role, which is what all primary care has always had, but it actually has a care management role going forward is actually a big deal. So we should all be watching that closely, especially those who are looking to do innovative technologies, processes, procedures, and we should actually either next week or the week after just invite anyone who wants to come and talk about CPC Plus, tell us what it's all about, how does it work, et cetera. I think we'll get some significant benefit.
Yeah, I think that's a great idea. We were talking about doing a DPC next week. I think that'd be a great follow-on to it because of the obviously tangent connection. Now, when you refer to the original CPC, is that Medicare code? I don't remember the number right now, but basically, if I spend 20 minutes with a patient every month, I can bill Medicare X dollars. Or is it something else?
No, that's called CPM. That's something. So CPC, it was an initiative started in 2012. It's part of the Affordable Care Act. It's one of the CMS Innovation Center initiatives. It wasn't very well described. It didn't have a huge uptake. But this new model, they have two tracks. They've described it pretty well, and it's called CPC Plus because they've added a few. Some would call it wrinkles. Some would call it innovations that should create a better uptake amongst primary care. What you're referring to, Don, is the CCM, the CPT code 99490, which means that if you have and that's a great point that you bring up. The difference is CCM requires you to have 2 or more comorbidities before they can be put into your population cohort, and then you have to spend 20 minutes per month with them during the month, track it, et cetera. And that's a much smaller population. The uptake has been very low as well. We've all been surprised. I mean, we've thought that if Medicare started reimbursing for chronic care and in care coordination like CCM, that the uptake would be higher, but it's actually been very low. We're talking about only tens of thousands of patients having been brought into the program, at least from what the latest statistics I've seen. Hopefully in 2016, we might see more. But CPC Plus says that if you are a primary care group, let's say you're a single primary care group working with a single payer, like one insurance company, you can combine and say that I'm going to manage the primary care responsibilities of N number of patients, and then you get N times the monthly fee, regardless of what specific services you are going to be doing for them. In addition, if through that CPC model, you need to perform your regular services. I mean, if somebody came in and they needed some additional services, you're going to get paid for that and in a separate fee-for-service model. So CPC, CCM, two different things, but related in the way that you're doing population management, not single patient management per fee.
Got it. Yeah, I think that'll make for a great topic then in a couple of weeks. To your comments on the HipMix stuff, that's where I find myself spending all of my time right now. And I've always been told your idea is I've heard people say your idea is worthless. That's a little bit strong, but I understand where it comes from now. And someone put it to me more recently. A great way it was, your idea is a multiplier, and after that, it's all about execution. So if you have a really great idea and some poor execution, then you've got nothing. And if you've got a so-so idea, but really solid execution, and you get a solid market fit, and you get solid marketing and everything else that you guys were talking about down there, you can get really far with that so-so idea. And it's hard to know that without going through it first. So.
Yeah, and I think that's why when you come to these kind of conferences, whether it's an HX Refactored where people are building things, or HipMix where, hey, I've built it, now I need to sell it and market it, you find that very quickly. I mean, there's a nice quote, I can't remember if it was Einstein or Edison, that said that vision without execution is hallucination, right? And that's what we're doing in healthcare, is mostly hallucinating that this is a great idea. I'm not sure how I'm going to execute it. I don't know how we're going to get paid for it. I don't know why doctors would use it and nurses won't, or why patients might use it and physicians won't, but I'm pretty sure it's a great idea. Right? That's what we've been saying, and I think it's right. We have been hallucinating that these are great ideas. But when you look at, and this came up quite a few times at the conference last week in HipMix, is there are people who have been doing marketing for decades. They understand what marketing means. They understand what content marketing is. They understand digital marketing. They understand the transformation. But you're talking about a world in which you're marketing products and services through multiple intermediaries. And that's still very, very hard, trying to convince. And until we see things like CCM and CPC, these things picking up where the buyer of the solution and the beneficiary of the solution and the user of the solution are the same team, then I think we're going to find the benefit. Other than that, it's going to take us a little while to go forward. So definitely check out, by the way, go to the hashtag HipMix or hipmix.com. A lot of those speaker decks are up, and you guys should start looking at those and start planning out what your marketing strategy and spend should look like over the next year.
Yep, and that community has a monthly tweet chat as well, and just generally very open and helpful too. So I recommend checking it out from that regard too. Cool. So we can jump into some of the topics from today's chat. If anybody else wants to come in, seats are open, have at it. But Shahid, from your perspective, I don't know if you had a chance to look into the blog, but the concept came up last week during our blab of this Dartmouth Institute, their Atlas project, uncover what they call supply-sensitive care. And in their words, it's very definitive from their perspective that this exists, and it's a thing that if there's excess capacity in a particular region, that region finds a way to use that capacity. It's the as David Harlow put out there, if you build it, they will come quote. So it's obviously a bit of a sticky issue, but they put up some data, they make a compelling story around it. Their primary comparison that kind of spoke to me was when they were looking at the difference between the admissions on cases where there was pretty fixed guidelines for where admissions should happen. It didn't matter what the capacity was, at least it didn't, from a statistics standpoint. Whereas if you looked at it for things that were a little bit more gray area, the line follows pretty tightly along. More capacity, more use of that capacity. So, David, welcome.
Yeah. Hi, David. Hey, David, it was good seeing you last week at HX Refactored. You were there as well.
Yes, that was a fun time.
it was. So no, I think you're calling it a sticky issue. I think it's so obvious that when you look at the supply, these cases, hopefully they qualified it for fixed resources with non-variable costs, and then non-fixed resources with variable costs. And there's a big continuum between that. So when you look at, for example, fixed resources with non-variable costs, like an MRI machine, it's always going to be sitting in a room. It's always going to be there regardless of what patients come in and out. And therefore, you need to optimize the utilization. It's called utilization optimization. You want to optimize the utilization of a fixed asset, which is costing you money irrespective of how many users you have. So if you were to spend money and say, okay, I need to sell something, I'm going to spend money for marketing and selling and business development around something that I have. The first thing you look at is, what do I have that's a fixed resource, which has a non-variable cost? Now I can say, look, my cost is N number of dollars per hour for this asset. And if I need to market that asset, I'm going to market it. If I need to biz dev around it, I need to sell around it. Well, of course, that supply is a fixed supply. You're going to need to sell that supply. And there are companies that sit around that do nothing but help you with the utilization management. So there's nothing hidden about this. It's been in healthcare for a long, long time, and it's not going anywhere, which is why telemedicine, which is why when you look at next generation assets, if you can buy on-demand assets, say, for example, we moved to an Uber or Airbnb-like asset where we said the supplies, which are a big spend. So the biggest spend in healthcare is human resources. There's really nothing you can do with that. They cost a lot of money for good reasons, and we'll put that to the side. The second biggest and third biggest type of spends are these supplies and fixed assets. So if you need to make money, you're going to have to figure out how to increase utilization of these fixed assets. So for example, if you have an airplane, which has 300 seats in or 180 seats in there, if you don't fill every seat, you're going to lose money, because once time passes, there's no way to get that money back. So what do? You optimize the supply. You optimize the demand for the supply that you have. It's exactly what airlines do. It's exactly what healthcare does. If you have 200 hospital beds, you better be optimizing to fill every bed that you can if you want to stay in business. So we should recognize that and say, okay, if we've been funding our hospitals in the last couple hundred years using fixed asset, non-variable cost type of models, and then we're wondering, why is the supply side driving this equation? We're crazy. The supply side is driving the equation because it's exactly what we designed for it to do.
Right.
Now, we change our design. That might be different. But so go ahead.
There are a couple of things that have tried to address that issue in the past. In the tweet chat earlier today, I tweeted in about my own involvement with the Certificate of Need program, the central planning approach, the 5-year plan approach to deciding how much of each particular healthcare resource do we need in a particular geographic area. And you can do population-based projections and so forth to arrive at a pretty good idea of what's appropriate. And that's something that I really believed in, and I worked on that program for the Commonwealth of Massachusetts for a number of years. But the problem, of course, is that things like that get politicized. So you can have the grand theory, but in the execution, we see often political influence being brought to bear, and the tax medallions of healthcare handed out not because they're needed, but because somebody has the inside track to something. That has sort of fallen by the wayside. I mean, that was sort of promoted. That approach was promoted on a national level, as you know, by federal legislation in the 70s, and that's sort of fallen away in all but a dozen or so states at this point in time. What came after that was sort of the managed care approach. You say, well, if we have central purchasing going on, then we're going to purchase intelligently. We're not going to purchase things that we don't need, and the market will weed out the folks who bought those 300-seat planes who didn't really need them, and they will fail. And those that bought the 180-seat planes will succeed. and we will have appropriate utilization on the 180-seat planes. And the problem there, and the problem that the Certificate of Need programs tried to address, is the sunk costs in the 300-seat planes are tremendous. And as I like to say, when I was working in public health, we could buy a whole lot of childhood vaccines for the money that was otherwise spent on these unnecessary capital expenditures. So there's sort of a lot going on, a lot of approaches to dealing with these issues. And clearly we've moved away from the sort of the central planning kind of approach. The managed care kind of approach hasn't been that successful over time because we still see, the edifice complex in healthcare continues, and the high cost through those edifices continues to have an effect on the healthcare economy. So various things that we're doing now in terms of value-based payments will hopefully try move the needle in this arena, but so far it's not really happening.
Yeah, and I think that, to the point that you made, the good news is these studies are capturing what evidence is necessary for someone to make the point. But what we're missing is that nothing in healthcare is truly accidental. It is designed in the way that it is because the way that money is raised, and how many people are going to go and say that I want to give money for a new wing of a hospital. Many philanthropists want to create a new wing of a hospital. How many of those same philanthropists are going to say, in a hidden way, I want to help optimize utilization so we have less people coming to this hospital? It's not to say that one is good and the other is bad, but one just looks cooler on your resume to say that, there's the Shahid and Shah Cancer Wing of hospital so-and-so. And so money flows into those areas, which are more interesting than not. And what we can do, this is now the business of healthcare, says, all right, so what do you do? Well, what is happening, for example, in automobiles and the sharing economy at large says that we don't need as many fixed assets with non-variable costs as we had before. And by using both technology as well as new processes and capabilities, let's start sharing the assets that we had. So if a new business wants to start up and say, hey, why don't we create a model in which, so MRIs are a bit hard, but let's look at anything that's a movable device, a movable asset of some sort. Could we start saying that, not every hospital needs every piece of equipment all the time. Therefore, I'm going to be able to create a wing of one type, portable supplies of another type that can be shared in between hospitals and other places. Like labs do this all the time. Not every facility has a lab. You put a shared service like a lab, then you do your specimen collection, and you send the stuff out, and you get your lab data back. This could be done in a more sophisticated way by doing exactly what David was saying, is look at what the needs are. And then we see, can hospitals, CEOs, and this is more about the demand side and the supply side, if hospital CEOs get together and said, look, I've got a hospital that's N number of miles from your hospital, why don't we see where we can become specialists? I'll take these kinds of specialties. You can take other kinds of specialties. Now, there are a whole bunch of antitrust issues in what I've just said, right? So I don't want you guys to jump in and say, hey, Shahid's crazy.
We'll bake you a cake, Shahid.
That's right.
So some hospital mergers are sort of premised on that kind of idea. And, in a perfect market, that would actually work. You do orthopedic surgery and I'll do endoscopies, and we'll each get really good at what we're doing, and we don't have to duplicate those services in our region. And that can work, and sometimes it does work. Just to go back to the MRI example, I spent a number of years working with clients who developed mobile MRI networks. You put an MRI in the back of a semi-trailer and truck it around, spend 2 days a week at one hospital, 3 days a week at another hospital. The eventual outcome of most of those networks, though, was that every hospital wanted their own MRI on a full-time basis. So the taste of that sort of started to grow the demand, and the supply then expands, and now we have the MRIs for everything, for everybody, perhaps too many of them.
Yeah, and I think that's the point here, is that if the fee-for-service model, which made those MRIs more valuable, remains in place, then that doesn't change. But in this mixture, as we move in from a little bit of a lot of fees for service for a little bit of value, and as the value equation changes, that may change as well. So these the ideas from 10 years ago of the sharing of these could come back with better technologies to say, I know how to get this fixed asset, these expensive resources, to different places, and that could be a new business model that the sharing economy can institute within healthcare.
Right, and certainly some of these services can be provided on a virtual basis as well. We were talking earlier about telehealth, asynchronous communication of various sorts, and that's, I think, sort of the real opportunity for cost savings in the future.
Yeah, another thing that I saw recently on this front, I got a demo from PocketDoc actually on their API, and the example they showed me was taking an MRI, your fixed cost resource, and outside of normal business hours, they were doing things like opening up appointment slots at like midnight, and they were offering those at discounted prices so that they were utilizing the resource 24/7 instead of just during the normal hours. And people can go in and through this API, PocketDoc had a lot of access from their database to pricing information. So they're actually suggesting to the seller of the MRI how much to charge for different points of the day, and then letting the person go in there, book right online, and putting the appointment right in for them. So it was a demo. I don't know if they've got this running in production anywhere, but just conceptually, it was pretty cool. A different way of looking at those fixed resources.
Right. And my point I think that's a great example. My point would be, it wouldn't be their job to run that. I mean, they're showing you that this is possible. Now, somebody in our audience should say, hey, that's a pretty good idea. Let me spend 18 hours, throw something together, and then, come to David or Shahid or Don and say, hey, where do you think this might sell? Could we try it somewhere? I think those are that's a perfect example of how a proper platform can let you do new things instantly that would take months for us to do in any other industry. So I mean, you've got guys like PocketDoc and others that are showing that. And what I especially like about PocketDoc is there's so much hidden value sitting in claims and payment processing that we're just not looking at because we're in a fee-for-service world. As you move into a non-fee-for-service world, not necessarily even 100% value-driven, there are going to be little things that we can eke out through these platforms. So anybody truly interested in the business of healthcare should start to look at these platforms and saying, what do they have hidden that they didn't even know was valuable? I can go discover this one little nuance and then help optimize that. Yeah,
right on. And tie back to your earlier comment too, is be aware of these things and then be aware of new models that come out. And when the CC Plus that you mentioned earlier, when that starts up, which of these tools can be applied in a new and creative way to address that new market?
Right. Hey, so David, did you see anything else at HX Refactored last week that was fairly unique? I talked about the platforms actually making their way in. So what did you notice last week while you were in Boston?
Right. I mean, I think the stuff you were talking about in terms of the Athena Health and the Allscripts platforms are very interesting, and really creates, recognizes that the EHR is a platform, not necessarily an all-inclusive tool, but really a platform for other tools as well. And as you said, there's data that comes out of the EHRs, and either now or in the future, there'll be data that will go into the EHRs through these connections as well. I attended one session at HX Refactored that Matthew Holt actually commented was probably the geekiest conference session he had ever been to, which is quite a statement right there, on the question of privacy, really, and sort of the use of information in different ways, and how can information be both protected and used. We were dealing with so many issues around privacy and security. And one of the speakers actually, the session was moderated by Adrian Gropper, and one of the speakers actually used the phrase quantum privacy, and at which point everything went way over my head, and I couldn't tell you anything more about that. But some of the other speakers were presenting information about open source tools that they're developing, for example, some based on someone who used to be at the VA, and some other interesting tool sets as well. So to me, that's sort of the future. The interconnections described by folks on that panel, plus the things like the Allscripts and Athena Health and others opening up APIs into EHRs so that the information can flow. And I think that's critically important.
Yeah, and on that privacy, Adrian is Chief Technology Officer at patientprivacyrights.org, which is a nonprofit that helps advocate for higher patient privacy rights. And really the quantum, I was laughing about the quantum privacy. Basically what that means is increasing the granularity, because right now we're basically saying privacy is at the massive record level, but that could never work because of the interoperability. If we want interoperability, we have to do it at the field and the smallest level. Another open source project that's by SAMHSA, the folks at HHS that manage mainly behavioral and mental health, we actually have an open source project called Consent to Share. So CONSENT and the number 2, share. Consent to Share is one of the few, forget commercial or open source, is one of the few products focused on providing granular consent and being able to let that consent, quote, certificate travel as the data travels. So if I consented for parts of my medical record, then as an HIE took the data from one system to another, the consent would travel with it. Now, these are all, I mean, this isn't going to help. Consent to Share is not that helpful for preventing hacking, but for people who are looking to follow the rules and follow the law, they're going to make sure that if you're not trying to steal the data, which is a different problem, that's a security problem, not a privacy problem. But if you're going to honor privacy, Consent to Share is actually a very interesting one. And so one of the open source organizations that I've tried to tie together OSIRA, which is the Open Source Electronic Health Record Alliance, and these folks at Consent to Share. And it's possible that in the next couple of months, they might be beginning some conversations to see how we can connect health records and Consent to Share over the long term, so that an organization like PPR, which I help advise every once in a while as well, there are organizations right now that all they can do is stand on a mountaintop and scream, "We need more privacy. We need more privacy. We need more privacy," but they can't get anything because we on the geek end, on the technology end, haven't built anything that can help them do that. So Consent to Share is one of those glimmers of light where I can see, oh, there's something here. If we can get this in, make it easy to install, manage, and connect, then we can go to everybody and say, dude, why aren't you using Consent to Share? Because I want privacy. I'm not just advocating it. I'm not just screaming about it. Use it. If you don't use it, I'm going to shame you, right? So you can have a shaming campaign that says anyone not using Consent to Share, managing my privacy is worse off. But right now, because we haven't given any tools and technologies, privacy is only as interesting as conversations at conferences.
So, Shahid, I want to press you on that. Because there are other schemas out there that would allow granular sharing or blocking of information based on patient consents. I'm thinking of Genetic Alliance and maybe other organizations that have put things together along those lines. And my question to that, and maybe you have some experience on this, is whether anybody cares. I mean, in the real world, yeah, sure, we can create this sort of technical solution, but does anybody really want to slice and dice their sharing or non-sharing of information that finely? A couple of years ago, there were some surveys done of engaged patients, people who use online services, and the general attitude was, virtually 100% of people said, yeah, sure, use my data if it could help somebody else. And 2/3 of those surveyed said, yeah, I expect that could lead to discrimination in housing, employment, and health insurance, but share it anyway because that's the right thing to do. There are finely tuned sharing options available on Facebook and other social media sites. Most people don't use them. So I'm just wondering, do you think that there's really going to be some uptake of these finely sliced sharing opportunities?
Yeah, so you have to think about this. That's a great question. 4 areas matter here. Area number 1 is where it's statutorily required, such as in mental health, behavioral health, where SAMHSA and those guys have to do it. It's not even a question. You just have to do it. And if you're not doing it, you're breaking the law. So in that case, absolutely. And we need to make sure we help people not break the law. Number 2 is regulatory wise. So HIPAA, once you move from the statutory side to say privacy must be maintained, HIPAA has some regulatory requirements, which we think, with a proper set of tooling could help. Number 3 is monetizable data sharing, to the point where you say, I'm okay with people sharing my data, but I want to get compensated if someone's going to make money on it. And there it would work. And there are actually a few health record banks and others that have been looking at this for the last few years, but there haven't really been the tools and technologies available to make it happen. And the last one is the one where you mentioned where, yeah, anybody's got data. If they take it, great. If not, I don't really care. What's happening is that there's so much data being made available in so many places. If we can create a healthcare business around proper aggregation of this data, proper mining with appropriate consent, then we can monetize it and help those people. And if somebody says, no, I don't want my data to be used, of course, it would never be used. But by aggregating it and packaging it properly, we actually increase the value of that data because it will get out. Otherwise, what happens is, and you know this certainly much better than I do, is everybody just says, oh, HIPAA, I can't do anything. Oh, HIPAA, I can't do anything. And then we're dead in the water. So what I think is going to happen is if we get this quantum type of privacy or even high granularity consent management, high granularity consent with proper data management, proper aggregation, a small layer of monetization, now we should see not an explosion of this sharing, but certainly an increase in the sharing and the value that we get out of it. So that's what I think in those 4 areas that there is value. But I'm with you. I mean, I've been skirting around the privacy side for a number of years, and until we can make it a true business value for privacy, it's not going to go anywhere.
Right.
Yeah.
Okay.
Yeah, in my experience, very few people just think about this at all. It's a pretty small percentage, and even when there's the big breaches, you'll get everyone's appalled, but it's only for about 30 seconds, and then they forget that happened and they move on. I personally have been part of, I think, 3 breaches through health insurers. Both of my kids have. My wife has multiple. It's like it doesn't even faze me anymore when that happens. So I think about it. I'm aware of some of the things that could happen, but it's definitely not something that I think is worth worrying about. To your point, so I think number 3, if we can find a way to monetize this and share some value with people, that might be the only way I'd see like widespread adoption from a public standpoint, at least. And I haven't followed it all, but there was an interesting one called Respect Network, I don't know, like a year or so ago that launched. And that was their whole premise. It was a 3-part arrangement where I was the owner of the data, and there was basically like a personal cloud provider data storage group that would be involved. I would select one of those that were participating in the network, and then I would basically open up my data to anybody who I want to share it with. And there was some, it was not just for health data. There was a whole bunch of different applications, but there was like personal health records out there. And I would say, yes, these parts of my record are allowed to be used there. And then there was opportunities where I could say, you're doing a study, I'm going to give you this portion of my data. And if that creates value, it was kind of like everyone involved in the equation got a cut, if you will. So something like that, if you can find a way to make it simple enough for people to do it and understand it, and then be able to get something back for it, I think you could see some uptake on it.
Now, I'm working with a couple of companies that are building systems and platforms that'll enable that. And my question is always, what's the value of an individual record? Is there value to an individual record above and beyond the value of having an aggregated million records and having done some analysis on those million records? So what would actually flow through to an individual?
Yeah,
this
right.
is the kind of question that was, raised in the past historically. And there's a famous lawsuit, Regents of the University of California, where a patient was kept having to come back for follow-up visits post-cancer surgery and treatment. And it turned out that he was not coming for his own good, but for the benefit of the clinician and researcher who had licensed and sold a line of cells based on stuff he had taken from his liver or whatever. The patient never saw any dollars on that cell line. There's a famous case of Henrietta Lacks, and there's recently been a financial settlement to her family. But there's the same kind of thing. What happens if there's a blockbuster drug developed based on the research from one individual patient? That I think for me would drive an appropriate, payment kind of question. But if it's based on an analysis of a million records, I'm not sure.
Yeah, I totally agree. And I think that's why that monetization side, as people look at it, 10 years ago, this was a esoteric and interesting conversation. There just wasn't enough data. I mean, we didn't have genetics data. We didn't have proteomics. We didn't have all the phenotypic data, the lab data. But this is real now. And we're entering what Steve Case, who I was at a luncheon yesterday where he was presenting his book, The Third Wave, where he said, wave number one was getting onto the internet. Wave number two was content and small amounts of transactions that we were doing, where there's still a offline and an online capacity. So you do a little bit of both. But the third wave, he's making the point that a company like Uber or Airbnb, which is coming in either at the late stage of the second wave or the early stage of the third wave, is where these companies could not have existed without all of the data, without all the technologies, et cetera. We're going to see those kinds of things in healthcare as well. And the conversations that we have in this around the business of healthcare, it shouldn't be around, what's my cool new app, or, do I do a little bit of data transfer? It is now assuming that we are now digital native. What are the next generation things that I can do that were just not possible before? Such as, I think it'd be great to say, if there was 1,000 drug participants in a trial and their data was used to make that money, then they should see some of that money, right? How would they do that? What are the legal ramifications? Those are months and years to be decided, but it's worth absolutely evaluating.
Right.
Excellent. So we're getting very close, we're beyond time already. So
as usual,
I say we wrap it up. It's been great. Thank you both for jumping on. Any parting comments?
No, just thanks, Don, for doing this. Your leadership here on HC Biz has been just terrific, and getting a bunch of talking heads like us, blowhards, to come on here and chat about this weekly is fun. Yeah. Thanks for doing it.
I'm enjoying it.
Absolutely. Absolutely. Thank you, Don. If I may, I'd like to drop a link here to a blab that I have started, which is an every other week occurrence happening on Tuesday afternoons Eastern. It was this week, so it'll be a week from next Tuesday, and this is the Health Wonk Review blab. There's a bi-weekly blog carnival called the Health Wonk Review that collects, it's like a journal club for blogs, if you will. Every 2 weeks, another one of us collects the posts from the previous 2 weeks and puts them together in a blog post and shares it out. And we've started having a blab about some of the posts, and I invite everybody to check it out next week, or you can look on my profile here on Blab and check out the last one.
Yeah, and I'll put a plug in for that as well. Health Wonk Review is over about 11 years old as a carnival now, and it's been around for a while. Bunch of smarties on there, so join if you can.
Awesome. Thanks, guys. We'll check it out. And everyone else will be doing a session on direct primary care next week. And it sounds like we'll probably follow up with that CPC Plus the following week. So stay tuned for that. And thanks. Have a great day.
Thank you. Bye-bye.